Today we're going to be talking about the interpretation of medical literature relevant to the statistics that are being used. We're going to go through several examples, but before we do, I wanted to give everybody the website for that software package that I used for the power and sample size calculation. So here it is. It's going to be in your handout there, since it's one of the slides, so that you can download it and play around with it as you wish. Okay, back to the talk now. So if you want to be an informed consumer of the published statistical analysis, you need to know what needs to be appearing in a manuscript. You need to be sure and keep in mind what to look for as far as the data goes, and we're also going to be talking about what you need to think about relative to subgroup analyses. So one of the things that you often see in the medical literature are these sorts of plots, which we've talked about before, these blobograms, as we called them before, the ratio plots, where they put the treatment effect according to subgroup analyses. In this case, the endpoint was death or MI, and at the top you see the overall results of the trial, and then they showed what happened by subgroup. And you can see that overall, you can see that the treatment effects seem about the same according to all the different subgroups except possibly female. Well, if you remember, according to our multiple comparisons issue, we would expect, with this many different analyses done, this many subgroups, we would expect that by chance alone, at least one of these would come out different, right? So it's not that unusual to see one of these to pop over on the other side of one. So the fact that females look like they had a treatment effect going in the wrong direction is not necessarily something to have concern about. It could be, but it's not necessarily something. We will see this in almost every odds ratio plot chart that we see like this from the literature from a major clinical trial. We'll see at least one go in the wrong direction. And what you always have to ask is, does it make sense clinically? Is it something we need to be concerned about? Have we seen it before in other similar studies? And if so, then we need to worry. And if not, then it's something we just need to keep in mind for future studies to watch out for. So in this case, it was females. And it was something that, this again was from the Pursuit study. It was something that had some people very concerned, and some people felt like that they should not be giving this drug to females at all, based on this analysis. Other people said this is just a subgroup analysis. You know, we have examples in the literature where people have done the zodiac signs and have shown that aspirin should be used in Geminis, which is what I am. I wasn't happy to see that one. But, you know, so we do have examples where you can do subgroup analyses and show that, you know, that even subgroups that don't make any sense can come out with strange results. So we looked further after having gotten more trial results. We did look further at this whole gender question. And so what you can see is that when we look at it, well, in one of the little teeny studies, again, remember that as the confidence interval gets wider, that probably means, if it's really wide, that probably means there aren't many patients in the study. If the point estimate is really small, that means it's a small study. The bigger the point estimate, the bigger the block, the more patients there were in the study. So at the very top, the PRISM study, that was a very small study. Well, for females, that fell on the right side of one, so that in the PRISM study, the treatment effect was good for women. Or it fell on the right side of being good. It certainly wasn't significant. But for all of the other studies, it fell on the wrong side. It fell on the side of being harmful for women. It wasn't significant, but it fell on the wrong side. For men, in all of the studies, it fell on the right side. Well, now we have something to think about. Now we really do need to think, well, maybe this isn't a multiple comparisons issue. Maybe it is more than just a subgroup question. So we have to now look at it further. Now, the reason I'm going into this is because we have lots of examples where people have taken one subgroup, taken it, done another study on it, done a huge multi-million-dollar trial based on looking at one subgroup that popped out from lots of subgroups, and it never came out to anything. So you need to really be very careful with subgroups and wait until you have enough data to feel comfortable with what you're looking at. Okay, in this case, we looked further into this, the sex issue, and one of the things that people thought about was, well, maybe it's because women come in with, as people have told me, they call it, what is it, the funny bunny chest pain is what somebody told me it was, where women come in and they have chest pain, but it comes out not really being an MI, but men come in and when they have chest pain, it really is an MI. And so maybe if we look at the troponins, then we'll find that with men, the troponins are going to be positive. With women, the troponins are less often going to be are going to be positive. So let's look at that. So what we did is we looked first of all at all patients, and if we look at all patients, then we see that with death across all patients, the odds ratio for men is going for the treatment to be better. This is the top row, and for women, it's in the direction for females to have more deaths. Certainly not significant. Now remember also, there were far fewer women in these studies than there were men. This is acute coronary syndrome. Okay, for death or MI, we have it that there were more men who survived from death or MI, fewer women on the treatment, and fewer women. And this is significant in both cases. This p-value is a p-value for whether this treatment effect is different within women than it is within men. So this is saying that that treatment effect is actually different for the women than it is for the men. Okay, so what about when we have missing data? A lot of these had missing troponin data. Well, what you see is that within the patients for whom they never collected any troponin data at all, well, in that case, we have a huge difference. When we don't know anything about them, then we see that the women are much more likely to have a negative treatment effect, and the men are much more likely to have the positive treatment effect. So if we don't look, then we're more likely to have the opposite effect. When we do look, then what we see is that we're more likely to have the same thing in men and women. So when we do look, then we have patients who have troponin data, then as far as death goes, both the men and women went in the direction of having a positive treatment effect for mortality. For death or MI, men had it going positive for death or MI. Women still had it negative, but it was not significant as of this point. Now, if we look at patients who had negative troponins, so according to troponins, they weren't having an MI at all. Okay? Well, in this case, what we see is that if they weren't having an MI at all, the drugs didn't work for anyone. The drugs were not effective. The odds ratios were on the wrong side of 1 for both men and women. If we look for the patients for whom they were having an MI according to the troponins, the odds ratios are on the other side of 1 for both men and women. This leads us to believe that it may very well be just that there are more women coming in who are not truly having an MI. We don't know that. There are a lot of women in here in this area with the missing data. We can't tell what's going on for sure in that group. We can make the assumption that those women are falling in the group who have the negative troponins, but we don't know that. So until we have better information, we can't ever say for sure. But our hypothesis is that what was going on was that women are being not correctly treated because they aren't being correctly diagnosed for the cardiac troponins, possibly. That's one of the theories. Okay? So that's why when we look at these subgroups, we need to be very careful, not just jumping on a subgroup, making a conclusion, and going from there. You need to really study the subgroup, think about what other studies have said, make sure it's a true subgroup conclusion, and take it from there and study it as carefully as you can. We're going to go through another study now. We talked about the target study before. This was the one that had one of the equivalency, the non-inferiority results. This is another one, another cardiac study looking at toriphamab versus abciximab in patients who got a procedure. And the event was an ischemic event to 30 days, the primary outcome. Again, it was powered to look at 88% power for non-inferiority based on having looking at data from the EpiStent trial to come up with the initial power calculations. And here are the events that were used in the 30-day composite endpoint: death, MI, or urgent target revascularization, where revascularization is defined as either a percutaneous coronary intervention or coronary bypass grafting. We saw this slide before. This is where we showed that for this primary endpoint, unfortunately for the company, it turned out that toriphamab ended up crossing the line of non-inferiority, the upper bound, so that it could not claim non-inferiority. Okay? It turned out that it was if you had done the test for superiority, abciximab would have been superior to toriphamab, according to this analysis. So what happens if they look further, which of course they did. You know, everybody's going to study the data a whole lot further than just the primary analysis. Well, if we break that composite down, then again, this was our primary composite here. If we break it down into the components, then what we see is that the toriphamab had almost the same. There were very, very few deaths. Almost nobody died. As far as MIs, there were more MIs in the toriphamab group. There were more deaths or MIs. Again, this is really just the MIs that we see because there were almost no deaths. And the urgent target revascularizations were pretty much the same. There were just very few urgent target revascularizations in the early time period. So when they did the subgroup analyses, again, pretty much all the same when we look at these subgroups. There was the one subgroup that popped out here. They showed a lot of interest in that subgroup. There was talk about maybe even looking at that as another study. Nothing happened with that, but there was interest in that particular subgroup, the patients who were not acute coronary syndrome patients. But their conclusions were right on line with what the data show, which was abciximab was superior to toriphamab in reducing the incidence of the composite endpoint at 30 days after intercoronary stent placement, and there were no differences in the rates of TIMI major bleed, but significant differences in minor bleed and thrombocytopenia were observed and favored toriphamab. I didn't show those data, but that was other data that were seen. Okay, so now let's go back to this endpoint. So if we take this endpoint at 30 days and we follow it on out to 6 months, then what we see is that the effect starts to go away at 6 months, right? So here we had a 1.6% absolute difference. By 6 months, we have about a 0.6% absolute difference. This is in the triple endpoint. Okay? So the difference is starting to go away. So if you were the company, you'd be happy about this 6-month endpoint. Now, what's happening here? Well, if we look, what's happening is, if we look at death MI, we have about a 1.5% difference at 30 days. It's significant at that point. It's no longer significant at 6 months, but the difference remains, the absolute difference remains about the same. It's no longer significant, though, because we have a higher event rate. If you have a higher event rate, then the relative difference has to go more. If an absolute difference stays the same, then you can't, let me say this again. As your event rate goes up, your relative difference also has to go up. Okay? So since the absolute difference stayed the same, the significance went down. It became less significant. So what happened was the significance, the events that were saved here remained here. No new events were saved, essentially. What we saw happening here remained during the 6-month period, is essentially what occurred, the deaths or MI. With urgent urgent target vessel revascularization, what we saw at 30 days was we saw almost none within the first 30-day period, but by 6 months, we saw several of them occurring, and there were significantly, well, not significantly, but there were more of them occurring in the abciximab arm. There were enough more of them happening so that it flipped those curves. Let's see if we can get back to this. So that it flipped these curves to be more similar. The absolute difference became much more similar than it was back at 30 days. So before, we had only the Torifaban was always lower. Always had a higher event rate. Now we have the abciximab has a higher event rate in one of the arms and in one of the events, and that is in the target vessel revascularization. That was enough to bring this composite event up to where they're more equal to each other. Okay? So when you're looking at this sort of thing, you need to ask yourself, what event is important to me? Is the three-way event important to me? Am I concerned about target vessel revascularization? You may be. The three-way event may be important to you. If so, then the fact that it becomes less significant at 6 months may be very important to you. Or is target vessel revascularization not that important? Is what's really important death, or am I important to you? And if so, then you need to realize that the absolute difference for death and MI remained constant over time. It did become non-significant, but it remained constant, and you need to think about that. So that's some of the things that you need to really think about as you're studying the literature. Don't just look at the p-values. Think about what is actually happening with the absolute and relative rates as time goes on. And think about what's happening with the components and the group parts of these rates. One other thing about these rates is if they ever show you, at least in the types of fields that we're in, some of your fields this is not relevant, but for some of our fields, if they ever show you a non-fatal event when the patients are dying off, you need to think about what is the death doing to those rates. So if you have some sort of an event like MI, and they're showing you the MI rate by treatment, what is happening if the treatment is by chance is killing one group more than the other? It has a mortality effect on one group more than the other. If one set is dying off quicker than the other, they aren't eligible to have an MI, are they? So it'll make it look like the MI rate is better in the group that has more deaths. So it gives you a very misleading result. That's why if you ever look at events that are non-fatal, but fatality is key in that particular population, you need to be sure that you also look at that composite with the fatal event, because it could be that the mortality can have a huge impact on that non-fatal event. Okay? Yeah. The question was, is it legitimate to break the outcome down into its pieces, given it was powered for the overall? It's legitimate to do it, but it certainly has to be and should be stated in the paper that it's not powered to do it. I mean, it's legitimate to do it because it's of interest, but it's a secondary question. I mean, it gets back to that whole thing of the primary versus secondary question. So it needs to be stated that, yes, we're looking at this, but we're looking at it as a secondary question, and here's the results as a secondary question. And that we did not power the study to look at this. That's how it should be stated. Yeah. Okay. I think we'll skip this one. Okay, so then we get into subgroups. Another study, the EpiStent, which was a study that this was based on. Here they are looking at diabetics versus non-diabetics, and the the feeling is in the community that in some in the community that based on this study, this drug does much better in diabetics than other patients. And that's because of this right here, partly. It's also because of the very top line there, with diabetics having that p-value 0.005. Well, again, if you look at death or MI, you see that it's not necessarily true that the diabetics are doing a whole lot better than the non-diabetics. If you look at MI, you know, it's not really all that true. And if you test to see whether they're different, then the tests come out saying that they're really not, that diabetics and non-diabetics have similar treatment effects on most of these outcomes. So again, just because somebody makes a statement in a paper that, or a drug rep comes in and makes a statement that one of these, that this particular treatment is the best for a particular subgroup, one needs to be very careful with these sorts of tables because it's not necessarily always the right interpretation for these sorts of things. So now we're going to jump from subgroups at baseline. So this was a baseline. This is something that we know when the patient walks in the door. The worst type of subgroup is the subgroup that happens after randomization. For those of you who are doing some sort of a registry study, it would be a subgroup that you're collecting after the initial hospitalization or after whatever your time zero is. So whatever your beginning of the study is, something that happens to the patient after that beginning of the study. That sort of a subgroup that you're defining is very, very problematic. So an example is we have a clinical trial and we want to evaluate the treatment effect of a new drug. And this drug is A versus placebo, which we're going to call P in this ACS population. And the endpoint is 30-day death or MI. And of special interest is the effectiveness of this drug in patients who got a PCI versus those who didn't get a PCI. So the physicians think that this drug works really well in PCI patients. And they're not so sure that it works that well in non-PCI patients. And they want to know, does it work really well in the PCI patients? So we have a patient. Here's an example of what one patient could be like. The patient gets randomized. They end up getting a PCI, and they end up having a death or MI. So they don't really end up getting a 30-day assessment. The 30-day assessment is that the death or MI follows forward, right? But they have the PCI, and then they have their event. That's what happens to that particular patient. I'm sorry, yeah, right. They have the PCI, then the event. Okay, another patient. This patient gets randomized. He or she has an event, never gets a procedure. Okay? That follows forward to their 30-day assessment. So they're going to be, at 30 days, we're going to consider them to having had an event at whatever time period it happened. There are other types of scenarios that we could have for these guys, right? We could have some patients who never had them. We could also have a patient who had an MI, then he got a PCI, and then he ends up going all the way through from there after the PCI, okay? We follow him on out to 30 days. Well, here's what happens. Here's the problem with this subgroup. This is what, when the data were presented to the FDA for this particular trial, this is the table that the FDA saw. This is, again, from the Pursuit study. Now, in patients who got a PCI within the first 72 hours, if you look within 96 hours, 7 days, or 30 days, these are the top part of the patients who got the early PCI. You can see that it looks like there's a huge treatment effect. P-values are very significant, 0.002 and 003 within the first 7 days. And it's even out to 30 days, it's still significant, 0.01 for the treatment effect. The odds ratios are saying, yes, there's a treatment effect, okay, within patients who got a PCI. if you look at the patients who did not get a PCI during the first 72 hours, the reason for 72 hours is that's the period, the window in which the patients are on the drug. Okay, so if you look at the patients who didn't get a PCI during that drug period, then we see the p-value is not significant. The odds ratios include the value of 1. They're going in the right direction, but they include 1, so they're not significant. So based on this, think if you were the FDA, this is a study of ACS patients, 10,000 patients, all sorts of patients. Some of them ended up getting a PCI. This is what you saw. Think what you would do if you got this. What the FDA ended up doing is they ended up saying that they would give them the indication for PCI patients. That's what they decided. There had been a study earlier that had been done in this same drug in PCI patients, and they said, this study supports that earlier study, so we will give you the indication for PCI, but we won't give it to you for all patients. Now, fortunately, they had a statistician who was very famous who went back and raised stink and said, listen, this is a study in all ACS patients. This was not a PCI study. You need, the PCI population was not a proper subgroup. You should either give them the indication for all ACS patients or not give it to them at all. And in the end, they got the indication for all ACS patients. But it took a while for that to happen. Oh, so this is the problem patient here. The patient who ends up getting the MI and then has a PCI and then gets the assessment. And so what we do is if we look at what's happening here, let's look at if we take those MIs that happened before the PCI out. So if a patient has an MI before they ever got a PCI, it's really not a PCI that should be an MI that should be associated with the PCI, right? It's really an MI that happened during the time of medical therapy. That they had this MI, they've never even had a PCI. They're still on medical therapy. There is no reason to have put them in that PCI group. They should be, that MI should have been allocated to the no PCI group. But it was put in with the PCI group. So if we look at what's happening to the events before a patient ever gets to the PCI, then you can see there's a whopping big treatment effect, 1.7% versus 5.5%. That gives us a p-value of 0.001. 01. I left out an O. Now if we look at what's happening as far as the same time periods, but we only include the events that happened after the PCI, not any events that happened before the PCI, now our p-values become much less significant. So the reason that that significance seemed so much different for the PCI patients than the no PCI patients was because there was such a strong treatment effect in those patients who were having an MI really early on. Because they had an MI on placebo especially, they were being sent to the cath lab. When they got to the cath lab, they were getting a PCI. Well, they were suddenly being put in that PCI analysis group. But they had already had their event before they ever got the PCI. Does that make sense? So the subgroup, so it was really the event that defined the subgroup rather than the subgroup defining the event. So the timing was all wrong between the event and the subgroup. So that's what the problem is when people want to have events and they want to have subgroups with events that are, they want to try to define subgroups that are based on something that happened after time 0. You have to worry about the timing of that thing relative to baseline, the timing of that thing relative to the end point, and all of the biases that happen during that hospitalization that come into the decision to give the patient that thing or not. So it gets terribly confounded. Another example is the support study. In the support study, This was a study of the effectiveness of right heart catheter in the initial care of critically ill patients. It's one of the things that they studied. So again, we had the issue of timing of the right heart cath relative to when they got to the hospital, relative to when they died. They need to have survived long enough to even get the right heart cath, and the patients who died early are all going to be in the no right heart cath group, right? Because they died before we could ever put the right heart cath into them. So we're going to have all those early deaths loaded up in the no right heart cath group, which will make that group look worse. And then we'll have the bias in who gets chosen for a right heart cath. Physicians, are going to choose different patients for right heart cath than those who don't get it. So if we look at the unadjusted analysis for the right heart cath from the study, then we see that it appears at both 30 days and 6 months that if you didn't get a right heart cath, I'm sure I got these backwards. I'm sorry, but I'm positive I got these numbers backwards. I'm sure that it's that you got the right heart cath, then you did worse. I'll check on these and let you know on Friday, but I'm sure I got this slide backwards. Anyway, if you got the right heart cath, then you did worse. So if some of the things that they did to adjust for the confounding that we talked about before was that if you only include right heart caths that occur within the first 24 hours, then we can get rid of some of the problem of the early deaths. We only have to worry about deaths that happen within the first 24 hours in that case. They also did this thing called a propensity score, where they calculated the propensity to actually receive a right heart cath and adjusted for that. So they adjusted for the likelihood to receive a right heart cath, and that kind of balanced out this bias for who got the cath versus who didn't. And when they did that, then they still get the same problem, they still get the same answer of the patients being more likely to die if they had a right heart cath than not, since they got a hazard ratio of 1.21. But they at least did everything they could to try to adjust away all of the biases possible. The publication hasn't come out yet, but the results have been presented for a study called ESCAPE. And the ESCAPE study actually is the randomized trial of this question. And in the ESCAPE study, they showed that there is no difference in patients who received the right heart cath versus those who didn't. So now we actually have the randomized trials results to complement the registry data that we've used to try to answer the question. So what we need to do is remember that the primary hypothesis is the only one that the study's designed to answer. Non-significant results may indicate there's just too few patients to detect a small meaningful difference, and that subgroup results need to be confirmed by subsequent studies before acceptance. We need to be sure and look at baseline tables to show the differences in baseline characteristics exist, especially when the sample size is small or the groups are not randomized. And if the baseline characteristics are not equal, we need to be sure that we adjust for those when we're doing comparisons. We've seen tables like this before. We looked at PCI versus non-PCI to show that these non-randomized groups end up having very different baseline characteristics. So we end up needing to adjust for those when we actually want to test for outcome differences in these groups. You need to be very careful of axis sizes. It's a good trick. If you look at this, it looks like that there's a huge difference in the event rate between these diabetics and non-diabetics, right? But this is the same plot. Okay? So here, look at where the y-axis, 0 to 0.3. This is the same plot going from 0 to 1. So just be careful now of what the y-axis is always when you look at a plot. I'm not saying one's right, one's wrong. They're both the same data. Just be careful, that's all. Check the ends. Always be sure. Do things add up? They often don't. They really often don't. Even when I do things, they don't. Well, even when I do. Often when I do things, they don't. So be real careful to check the ends and try to figure out why they don't add up if they don't. Look out for missing data. it's often the case that things start dropping out, and try to figure out why things start missing from the tables. How will the missing data influence the results? Think about that. Can you account for every patient in the sample? Are there confidence intervals or some sort of error bar with the estimates to let you know how believable the estimates are if they don't have a p-value? And here are some references if you want some guidelines on some statistical reporting. Here are some good references for other people who have written some things on how to report your results in manuscripts. Are there any questions? Okay, I guess I'll see you all on Friday then. Your last question.